Hey everyone, thanks for tuning in. Today I'm diving into the world of ECGs and the various heart disorders they can unveil. Whether you're a seasoned healthcare professional or just brushing up on your knowledge, this quick guide will keep you sharp on the essentials. Let's get started. First up, atrial fibrillation or AF on the ECG. You'll see an irregular rhythm with no distinct P waves. The ventricular rate, it can be fast or slow. What's causing this? It's the irregular electrical activity in the atria. Next we have ventricular tachycardia or VT. Here you'll notice rapid wide QRS complexes clocking in at over 100 beats per minute. P waves might be missing entirely. This happens due to abnormal electrical activity originating in the ventricles. Now let's talk about bradycardia. The heart rate drops below 60 beats per minute, but the rhythm remains regular. This can result from sinus node dysfunction or an AV block. Simple yet crucial to recognize. On the flip side, we have tachycardia, where the heart rate spikes over 100 beats per minute. The rhythm can be regular or irregular, often due to abnormal electrical circuits in the heart. Premature ventricular contractions or PVCs are next. These show up as early wide and abnormal QRS complexes without a preceding P wave. They're followed by a compensatory pause. This is due to premature electrical impulses from the ventricles. Then we have premature atrial contractions or PACs. Here you'll see an early P wave with a different morphology followed by a normal QRS complex. This happens due to an early electrical impulse from the atria. Second-degree heart block comes in two types. Type 1, also called Ventricular, shows progressive PR interval lengthening until a QRS complex is dropped. Type 2, or Mobitz type 2, has dropped beats without prior PR interval lengthening. It's crucial to identify the impaired conduction in either the AV node or bundle of his in third-degree heart block. There's no relationship between P waves and QRS complexes. The atria and ventricles are beating independently. It's a complete block of electrical signals between them. Myocardial infarction or MI shows up with ST elevation or depression, T wave inversion, and abnormal Q waves. Acute MI shows ST elevation in specific leads, while old MI has pathological Q waves indicating previous heart muscle death from artery blockage. Long QT syndrome features a prolonged QT interval, often over 450 to 500 ms. It's triggered by genetic mutations or certain drugs leading to abnormal ventricular repolarization. Pericarditis is identified by diffuse ST elevation with a concave shape and PR segment depression. This is due to inflammation of the pericardium. Hyperkalemia shows tall peaked T waves, prolonged PR interval, and widened QRS complexes. It's caused by elevated potassium levels in the blood. Lastly, hyperkalemia presents with flattened or inverted T waves, U waves, and ST depression. The culprit? Low potassium levels in the blood. And there you have it, a quick rundown of common